single webinar every single day. And these webinars have covered a variety of things from clinical mastery and clinical subjects with the Geek Out Gang in lockdown to financial mastery and financial subjects, managing your finances in these difficult times or, elements of how do we recover from this. We've got business masters, etc. And we've also done personal mastery, which has been all about yourself, your mindset, your thinking. All of this has been done to keep your spirits up during the tubules, during the lockdown period, and to bring the dental community worldwide together. At this time, something that has been very, very, very important has been knowledge of what has actually got us here in isolation, COVID-19. We held a 4 hour long COVID symposium a few weeks ago. That was very useful because we discussed microbiology, microvirology, epidemiology, immunology, personal protective equipment, how to put protocols in practice. We talked to hospital surgeons. We talked to a specialist surgeon in the hospital who talked about some elements of masks, etc. We gave you a good background on this subject. Today, what we want to do is two important things. For those of you who are already signed in, you will see that this webinar has started. For those of you signing in later, this will probably be seen later. This webinar today will cover two aspects. I am going to speak for the first 30 minutes or so about giving you some thought processes of you having to create protocols in practice. And the second part of the webinar is going to include Dr. Tarik Sembesh and his team who do respiratory protective equipment. They will be talking about masks, what respiratory protective equipment is, what are the rules for an employer, the insides and outside of all that. So I hope that you really, really find today's evening useful. It is going to be a slightly longer session than normal, but not to worry. If you do see some elements and see some later, that's fine. Most importantly, if you are signing this a bit later and you want to jump to another bit, feel free to use the dial below to go ahead with that. We're more than happy to help you through. Now, what I will start with is the protocols that I would like everybody to really think about overall. And I hope that those protocols are something you can think about as going back to practice. So I will be sharing my screen now, and I will take you on once I've got my screen sharing done. If you do have any questions, any queries, anything of the sort, please feel free to type your question in the red box below. That's where I will answer them as we go along. And as the team of Dr. Tarik Sembesh and his colleagues come along, we will pass it on to them to continue with today's evening. So welcome to today, all about thinking about going back to practice. Now I hope you can see my screen and my slides. What we're doing is talking about going back to practice. We've had almost 6 weeks of lockdown in the UK, but various parts of the world have had various elements of lockdown. So therefore, we have to plan ahead. Now, some 2 weeks ago, we did the COVID symposium, and this is a follow-on from there. The 4 hour long COVID symposium that we did is available on the website. You can go to the Tubules Live Aid section on our website, go to past webinars, and just scroll down a little bit, and you will see the Tubules COVID symposium. Or you can go to the link here. It's a fairly long link. So what I will do is just in a while, I'll post it down in the comments if you missed it. We had nearly 2,000 people watch this, talking about all the possible science and knowledge we have regarding COVID. We had Dr. Jonathan Collier in that, a surgeon from Chelsea Hospital, Dr. Sophie Collier, who's the head of infection control at the Royal Free Hospital. We had Adrian Shields, who's an immunologist at the University of Birmingham. We had Joe Russell, Dr. Adil Khan, who is a oral surgery specialty doctor in London, and then I carried a little bit of the stuff from there. But today's agenda is me going over some information regarding going back to practice and giving you some thought processes to work with. And then Dr. Tarik Sembesh and his team will come through to talk about respiratory protective equipment. For those who want CPD for this, CPD is available for the premium members. It will be in the online CPD section of our website in due course, but this lecture is open and available for free for everybody. The CPD tests are tied to your IPDP, and therefore it is difficult to make all that entirely accessible the way we've built it. But the lectures have all been made free, so please take this knowledge and apply it to your practice as you find comfortable. Now, I want to make you think about things as you go back to practice. What I'm going to go over with you is literally showing you and making you think about things that you can sit with your team and implement. What I have to start from is that there are a lot of unknowns here, and the evidence is still emerging. For example, we know that aerosol is around there. We don't know the viral load that happens in aerosol generating procedures and what level of risk this presents. When I say what level of risk, we mean which patients are going to get it. What we do know is that everyone is at risk here. Remembering this, remembering that all the facts are unknown, not knowing what aspects are most important, what are not, we have to think most importantly about reducing this risk as much as possible in our practices and increasing the safety of the patients and the staff as much as possible. And the big reason for this is because if a patient does get COVID-19, they may recover from it, the morbidity may happen, and some of them is a sad aspect of the mortality that we have been hearing through the media in whichever country of the world we are in. And therefore we are trying to reduce the risk, and because the research is still emerging, some of the details are not known, and what we're trying to do is really try and create something as a full protocol that reduces the risk at each stage of your patient journey. I often get asked by people, what do you think I should get as an air purifier? A single thing will not answer this, and some of those answers are not very clear. So every little thing you do in practice will help you reduce that risk more and more and more. You get a patient who comes in, they've just come through public transport, there's a risk they may have picked up the virus there. All these little things happen. This is a wonderful article, by the way, on aerosols, drop sets, what's an aerosol size. What is a droplet size? What is airborne spread? All of this worth reading here. I'm not going to go into that detail. You can look at the COVID symposium we did, or alternatively, you can go ahead and look at the information available on the web that will give you all of this that you need. What I do want to point at is this. An aerosol generating procedure is a medical procedure that creates aerosols in addition to those that the patient creates regularly from breathing, coughing, sneezing, and talking. So the medical procedure that does this. However, is that every single medical procedure? We know the use of a handpiece with water is aerosol generating. Use of an ultrasonic, yes, it is aerosol generating because it'll mix with the saliva and create that mist. But would you say 3-in-1 is aerosol generating? Strictly speaking, it is in addition to what the patient creates by breathing and coughing. So it is aerosol generating. But if we go to that level, how much work can we do? So we have to look at this very, very, very importantly. And this is where RPE becomes important. And that's why we've got the team on board today. We do know, and we probably have been told about this again and again, about social distancing, which is physical distancing, because it has been shown that when someone sneezes or coughs, the heavy droplets sink to the ground, but the aerosol droplets can go up to 2 meters. They can go further as well, it's been shown. We do know this aerosol, but like I said, defining an aerosol generating procedure becomes important. We don't know what the viral load is in the air in the patient. We don't know what a critical load is to convert someone who's asymptomatic into symptoms. So there's a lot of things to think about that may increase or decrease the risk. It's based on our limited evidence. Elements about the pathology of this virus and new um, uh, thoughts come through with that. Comorbidities, patients who are rigid, who have other illnesses, are more likely to get this risk. All of these things need to be put together to understand that some patients are more at risk, some are less, etc. And that reinforces the point I said. You must follow through an important protocol within your practice. Now, each one of your practices are different. Some of you have large waiting rooms, some of you have small waiting rooms, some of you have multiple surgeries, some of you have single surgeries. So what I have done is worked with the team to look at how some of these risks can be reduced as far down and how we can increase safety. And we came up with 37 questions that can help you in your practice to do a risk assessment for that area and then to do a protocol. And those are the 37 questions we are going to pose to you. You may have more questions. So if you feel that there are certain questions we should insert into this, please feel free to put the comment below, because that will become very important for us. We've actually created a Word a PDF document of this risk assessment and protocol questions. For each question, you can write down your risk assessment in practice, what you think the level of risk is, and what your practice protocol is for this as well. And you do this, this almost becomes your practice policy, your practice procedure system that you can give to all the staff, that you can put forward to any regulators to say this is what you're doing to really reduce that risk and increase the safety for yourself, your patients, your staff. Now, really, really important to go through all of this in as much detail as you can. And the way we've divided it is into 5 paths. Thinking about what sort of things to look at before the patient arrives, upon your patient arrival, in the surgery itself. That includes also as patient walks out of the surgery, protecting your staff, and then any waste disposal and other miscellaneous items which you may have specific to your practice that is there or that we have not yet thought about or included. This document is collaborative, so everybody coming together will be able to create something that helps the entire profession worldwide. There have been a lot of webinars, and I hope this helps accordingly. Here's some things to think about for protocol. Before the patient arrives is really, really important, because I think it's important to keep some things in mind here, to keep some procedures that you need to really make your team make it almost part of the routine, in my opinion here. So, firstly, will you stagger your diaries so that not every surgery starts at the same time and your patients are spaced? And if you do that, how? That's the first question I look at. So instead of everyone starting at a specific time, say 9 o'clock, and you have multi-practice surgery, can you all start a little bit later so that the patients are not crossing each other, the staff are not crossing each other, and everyone has a start time that is convenient for everybody? And this comes under the booking patients and managing diaries. Alternatively, as you start going back, will you open one surgery at a time and then slowly start increasing to 2 surgeries, 3 surgeries, so on and so forth? I don't know actually, but these are things for you to think, because every practice is different. We cannot give you full protocols, but what we can give you is some thought processes and directions to go with these questions. So booking patients and managing diaries. These are the first 2 questions. Before the patient arrives, these are the next things. Worth calling them to check, are they symptom free, or do they have any symptoms which may be relevant to COVID? Whatever it is, they've had temperature, they've had a fever, they've had a cough. Phone them up maybe the day before. So your risk may be that certain patients may have it. Your protocol is phone them the day before and ensure that they're okay. If not, do you need to reschedule their diary? And that becomes very important. Will you get them to fill in medical history sheets remotely? And does your software allow it? What's your risk assessment here? Generally, patients come to our practice, sit in the waiting room, the patient lounge, whatever you call it. They're given a tablet or a piece of paper which they update. We're trying to minimize this. Now, I understand certain software systems are much better at allowing this, and I think Software of Excellence has allowed you to be able to remotely fill in medical histories. There is an American system by the name of Incognito that allows you to do this as well. Patients fill it in and it comes to you as a PDF which you can print out or download and save, and they can update it on a monthly basis. This means that patients are spending less time within the practice, within your reception area. Important thing to keep in mind, will your medical histories have some COVID specific questions? Will your medical histories have some COVID specific questions? Is been put in there because this is a good way to find out direction for your patients. And you know, sometimes you phone them up and they say, no, I'm fine, I'm okay. And then they answer these questions and you pick something up. At least you're putting that in place to mitigate or reduce the risk. Other things like, will you take payment by phone prior to their arrival? Because if you take payment by phone, it reduces the contact time in practice. Remember the first thing about social distancing, physical distancing. While this risk remains, while we haven't got a vaccine in place and we know that this is still around within our society or communities, we're trying to reduce as much contact time, I hope, and that's what we're trying to do. So we hope that this will help you through. That's before the patient arrives. Upon patient arrival, there are various things. If you've got to think through your patient journey here. So upon patient arrival, what you have to keep in mind is, will you ask them to wait in the car, in the parking lot, and then you phone them or buzz them as they walk in when you get a buzzer? Or do you actually say that have in the waiting room, but your waiting room is large enough so you can social physical distance them? That becomes important. Also, how will they liaise with the reception and administrative teams? Will they speak via phone? Will you put a 2 meter distance from the reception desk? I went to my local pharmacy and they have a 2 meter distance with a blue tape on the floor. So when you buy something, you go to the blue tape, and then they have some sort of a net that you put everything in and pass it to reception, and or the pharmacist or the person taking the payment. They scan it all in, they put the card in this fishing net sort of thing, send it to you. We put your card pin so the distance remains. Or some people may put perspex shield barriers or something to create that. You could also get your reception teams to wear masks, possibly, and visors. It's all about creating and helping that distance, especially now as the risk remains. As the patients come in to practice, what protocols will you follow? Will you do temperature checks on the patients as they arrive? That would be useful, I guess, and something to write down. Other things that you can do is, will you give them masks to wear as they come in the practice? Will you put a box of masks there? Will you put disinfectant there so they can clean their hands? Will you put shoe covers, head covers? How far will you go? You've got to make this risk assessment and decide. But these are things to think about the patient arrival workflow. Are there any specific or sensitive tests that can be done to identify risks or for diagnosis at the moment? If you heard the immunologist at the COVID symposium, I would think not. But at some point, if they come along, this enters into our protocol, possibly. Will the patients be given masks to wear, shoe covers, head covers? That information I've just spoken through. Important as well, will they walk through the practice on their own, or will they be accompanied by a member of staff? If so, who? So you could have, depending on your practice, again, I'm trying to give everything, is can you have a specific, I don't know, COVID disinfection nurse or a nurse who guides the patients through the practice, ensuring that their journey is very, very specific. They're not going everywhere. If they need to visit the loo, then somebody has a protocol that this patient visits the loo, needs cleaning, everything along those lines. These are 12 different questions to think. How will you ensure protection and safety at reception? We discussed this a bit earlier, including their masks that you may want to give the reception staff, perspex shields. Will you add tape on the floor? All of these things are being put as specific questions, yes, no. And you decide on the protocol for your practice. If you do want this Word document, we're happy. We'll put it on our website for you to download and fill it in for your practice with your team and get a protocol in place. I hope this is being useful. In surgery, very important, the risk assessment and protocol documents in surgery. Firstly, what procedures will be defined as aerosol generating procedures and what procedures will be defined as non-aerosol generating in your practice. I say this in your practice. I know we kind of have a very good idea overall, but as you can imagine from the questions, for example, Douglas Miller has said, is there an advantage in using electric motors rather than turbines in terms of aerosol generating? Little things like this you need to put in there. 3-in-1, is it aerosol generating? It is. This enables you to realize non-AGP procedures are lower risk than AGP because the mist isn't being created. How much of a lower risk, we don't know. But at least you have a definition in your practice about what's AGP, what's not, and therefore for an AGP procedure, what are your protocols, and for a non-AGP procedure, what are your protocols? Will the patient get a preoperative mouthwash and nasal spray as they come in? There has been some talk, some papers, some evidence at a certain level showing that certain mouthwashes, whether it's hydrogen peroxide, peroxyl, iodine-based mouthwashes, do enable some sort of virucidal effects. So you could do this again, give the patient a full mouthwash. Some practices have also instituted that as the patient comes in, they will have to wash their hands thoroughly in the surgery before they sit down. Will you implement this? Do you feel this is a risk in your practice? And then do you feel this is a protocol you would put there? Will you give the patients protective aprons, sleeve, or any sort of clothing that they need to put on in addition to the masks and shoe covers that you probably gave them as they walk in? You may find as we go through this, some of you may say, Jesus, this is a bit too much. Some of you may say it's too little. What we are putting there is questions for you to answer with your teams and put these protocols in place. Once the patient has sat down, what will be the nurse, clinician, nurses, staff, everybody else's hand hygiene protocol? I say clinician and nurses, but actually the whole team. And this is extremely, extremely important because the hand hygiene protocol is something that has been shown to really make a difference. In fact, the general cross infection has been shown to really make a difference in some hospitals in South Korea, Hong Kong, for example, the Queen Alexandria Hospital. How will the staff be asked to wear, or what will the staff be asked to wear during AGP and non-AGP? Sorry, that should be what will the staff be asked to wear. This is where the previous question, when I said what procedures will be defined as AGP, come into mind, because then you can decide what's important. And this is thinking about eye protection, the visors, the eye goggles that we currently have may not be sufficient. You need goggles that are a bit more tight fitting. Masks, respiratory protective equipment. I'm going to leave that to the experts who will be coming to us in the next 9 minutes. Scrubs, what sort of scrubs, what sort of gowns, disposable or washable. All of these things need to be kept in mind. What we have figured out in our practice where I work is that we will be having full-blown FFP3 masks. Everyone will be fit tested. We will have eye protection. We will have visors. We will have scrubs and gowns. And we will include that as additional time in the patient diary. Can your practice allow that? We don't know really. Will your practice be able to enable that? You have to decide what's important and how you do that accordingly, because we all have different diaries, different types of patients, etc. Also, what is important in this is that you have to decide what kind of scrubs you put in, what kind of masks you put in, and for what procedures. Will you have a rubber dam protocol? because rubber dam apparently has been shown again to reduce the risk of aerosol production, and therefore the rubber dam protocol may be important for your practice. You may say X number of procedures are at higher risk, and these procedures will need rubber dam. And so you go through that. I'm a periodontist. Rubber dam is very difficult, really. So we may need to think of alternatives. As a periodontist, some of the alternatives we are thinking about is not to use ultrasonic and simply focusing on hand scaling, which I've done most of the time. So I'm probably one of the outliers. Possibly using things like isolite, etc., which I will discuss in a short while as well. But this is important to work through. This is very cool as an article, Science Direct Topics, Medicine and Dentistry Surgical Gown. And if you look at that, you will see quite a few bits on an article on surgical gowns. Surgical gowns have specific sort of properties that you need. It's a barrier against disease transmission, as it says here, but it needs to be certain material because you need to be water resistant. The virus has been shown to sit in on surfaces for between 36 to 72 hours, and it stays in the air for at least up to 3 hours in some studies. These are still early studies, by the way. Therefore, you have to be aware that the gowns you have are at least water repellent. And those of you who've been doing implant surgeries, you will have all of these things in place. You will be doing these sort of things before in many, many ways. The surgical drapes for your patients, the head cover, you will be doing all of this. So it's important. I will answer all your questions you're putting down there in a short while before I pass it on to the team of Tarik and Besh. Will the surgery have surgical gowns and FFP3 masks and or respirators? Are questions to ask for each surgery. Will there be zoned areas in the surgery? If you saw the webinar in the COVID symposium by Adil Khan, the specialist doctor in oral surgery, in their hospital they had a green zone, an orange zone, a red zone, and the patients followed a certain pathway. They could do it. Can you do it in your practice? But that would be very useful. Will you have any high volume suction systems? There's Isolite, there's Backstation, there's quite a few. There's one new one I've seen where it's almost like a Perspex shield over the patient's sort of face, and in between there is high suction. It suctions up to 20 liters I think it's per second or per minute, very quickly, and it's been developed really well. Neil Dupree has been talking about this. I think today he couldn't be with us, but these are some of the things to think. The aim of this high volume suction is that if you're using an aerosol generating procedure, it just sucks everything up really, really well, stopping splatters, stopping or reducing, I should say, droplets, reducing them from settling down in systems. So very useful. How will the donning and doffing be carried out? So donning is basically what you do before surgery, where you put your gown on, you put your cap on, you put your mask on, then you put your gloves on, your goggles on, your mask on, then your gloves on. And when you do doffing, as you'd normally do in surgery, you take your gloves off first, then you take your surgical gown on, your headgear off, etc. This is very useful to put as a protocol. This is how we will do it. But you can imagine if you go through all of this, think about it. Going back to here, you ask question 17. This is an AGP procedure. This is what we are going to wear as question 22. And then you go to 27. This is how we are going to operate through. Your practice then has a really good system that your whole team knows. And that's why we've put these questions in the order and the way we have. How will post-treatment appointment and admin be managed? And something very well to do. So that's important to keep in mind. Will you do the admin in surgery and then the patient walks straight out with the nurse? Will you do the admin at reception desk? Then you have all the bits there. These are things to think about. FFP3 masks and respirators, I will put that a bit later on with the team. They'll tell you more. Once the procedure is complete, so managing surgeries post-treatment, once the procedure is complete, how long will you leave the surgery to allow time for the air to disperse? Will you open windows? Will you have other air filtration or air purifier systems or fumigating the room? This all this sort of information. Remember, the air filtration and air purifying systems, the data, the evidence behind it is still fairly new. So we don't know if they're really vericidal, what they do. What we do know is they turn the air around a bit faster. Different places have said different things, and I'll talk to you about that in a while. Different countries have different protocols. What will your wiping protocol be for the surfaces? In truth, should be a huge difference to what you have now. The thing is, when you've actually done a procedure and you have to then leave that surgery for, I don't know, 15, 20, 30 minutes. Normally, when we've done the surgical or any procedure, we sit in that surgery, turn around and make our computer notes. But this, you have to leave the surgery for the air to circulate. So you may need to have a new protocol for writing notes. Do you go to another computer in another part of the practice? Do you go anywhere else? We don't know. Will the staff need new PPE after re-entering the room? That's something for you to think about as part of your practice as well. And the final bit about these risk protocols is your staff, very important. How will you ensure your staff's reduced contact? Example, staggered start times we talked about, staggered lunch breaks. Perhaps in the staff area, you say only 2 people allowed at a time. So these sort of things to think about. What gowns, masks will you provide to the staff and the protocol for this? Some of the earlier questions cover this as well. And how will you ensure that the staff room, the staff areas, they're not crowded, and this staggered bit helps there as well. Some of the thought processes. And then waste. Do we need to think about anything regarding waste and disposable systems? We don't know. Anything else within your practice that you need to think, for example, who's going to disinfect the toilets, etc.? We don't know. But these are some of the 38 questions we have put together for you to sit down and work through this as well. And this is really, really going to be important to think about. Invariably, all of this will have economic, financial implications. And how do you relate that to your patients? We hope, we work in the UK in NHS and private systems in different countries who are watching this. You work with different systems. How will you implement that? And all of these things need to be, taken in mind. Yesterday, I think it was the FGDP webinar where I heard that, getting additional PPE for patients, it'd be anything between 26 and 38 pounds per patient. That's not a low cost, and you have to communicate with patients. One of the other protocol questions we may put into this is how will you communicate with patients prior to their arrival about the increased risk and what you're doing to think about their safety, because your patients will feel reassured and possibly come along. Now, what I do want to do is my friend Mojtaba Deganpur in this lockdown has found that his sleep has been a little bit difficult, and he has been doing a lot of reading. And you can see 10 countries he picked, and 10 of these sort of more advanced countries, some of them like Italy and Spain, who have had really high levels of COVID and are slowly coming back. Countries like Germany and Switzerland, who have pretty much been working through this crisis. Dentists in these countries have been working through. Countries like Australia, who did a lockdown quickly and their risk of COVID got to level 3, not level 5 like us. He took their advisory bodies and he's seen what guidelines, protocols they have come out with overall. You can see non-AGP, most of these countries have said a surgical mask. Again, this is open for sharing. We can put it in the work document. Mojtaba has given me permission. Mojtaba Deganpur put in a lot of work here. AGP procedures, you can see some countries say N95 FFP2, some say FFP3. But what we have to keep in mind here is some patients may be COVID positive, and we need to think about that overall. Even the gowns have been put in there. Some say it's the patient's discretion. Some say use APGs. Some say disposable plastic apron generally. So again, there is a bit of difference there. And then there are other things across here. So Switzerland has, for example, said wear the mask for 30 minutes after the AGP, up to 8 hours use, ventilate the room for 15 minutes minimum. Spain said 5 to 10 minutes post AGP ventilation of the room. So it's gone from 5 to 30 minutes depending on the protocol. Germany was interesting to say there has been no real evidence of aerosol transmission. However, avoid AGPs if possible. So it's a real mixed bag. What we do know, and I go back to where I started, the real important thing in this is that we do have a patient risk that we have to keep in mind. And it's the risk we want to reduce and the safety, especially at this time when we do not know everything about this virus and its implications and the epidemiology and everything. Therefore, we have to be much, much more vigilant to reduce that risk of death or mortality. I'm going to answer a few questions for 2 minutes, and then I'll come on the chat itself and give you the answers as well. And then it'll be passed on to the team as well. Thank you very much for all the information and comments that you've put through there. It is most useful. These are the things that we are trying our best to help you through. So we can't give you the answers, unfortunately, but we will give you all the possibilities. Margaret Walton, I started this a bit early. The main team is at 7:30. Not to worry, you can rewind this, so don't worry about that at all. And this is very, very important, right? Let me see what questions we have very quickly, and then the team is on. So let's look here and see what there is. Is there an advantage in using electric motors rather than turbines? Douglas Miller, I'll try and get those videos a bit later to show you where NSK showed the difference, and electric motors reduced, or there was less aerosol from electric motors. However, there's still aerosol. How to deal with asymptomatic corona patient, Kem? We just need to be very, very vigilant. If you think they're asymptomatic but they have it, I would probably say don't see them, give them 14 days isolation and then coming back. We will send you this link to this document. How long, Erica says, do we need the patient to use the mouthwash for prior to dental treatment? 2 minutes. That's my standard protocol. That's what I use for perio patients. Angela Roxbury, you should be washing your hands anyway. Agreed. This just makes it stricter to make sure you follow that protocol. Kimia, where would you get FFP3 masks? Wait for the team to come on. And it is right, Benjamin, as you say, it's very well to wear FFP3, but you won't be able to perform dentistry properly due to humidity goggles and fogging up. Let's wait for the team to hear and give this information. The added financial implications that you talk about, Olufunke, are extremely, extremely important here. And we have to think about that. I don't have an answer for that yet. And PP that's sufficient for non-AGP that Wayne Carolison asks. You've seen the document I've just put there from different countries. That maybe work as a guide for you. And it's important. Nia, as you say, for non-AGP, is it safe to wear non-general surgical mask if the patient is sneezing or coughing around the surgery? Cough and sneeze is an aerosol. It's not an aerosol generating procedure. It is an aerosol. If they've been coughing, it may be best to just get them to wait of any important, really. That's my thought process here. So I will actually give you a bit more time to write your questions in. Right now, I do want to really bring along the team who are going to talk about the respiratory protective equipment. Before I do that, for those of you who are listening to this right now, you will see that in the chat, I'm putting a little link. That link is a Survey Monkey for a webinar. If you spend just a few moments here, click on that link as a separate window, just so that we can write you can fill that in while we introduce the team, and then we come along. So I'd like to introduce Dr. Tarik Shembesh, Dr. Sami Darwish, Kareem El Bogdadi, Kate Dini, and Ashwin Baba. I hope I pronounced all your names correctly. How are you all? Let's stick with Tarik. I've been speaking to Tarik, so welcome to the show, Tarik.
Hi, thank you, Drew, for the opportunity, and thank you for giving us an insight and very useful resources.
No, you're most welcome. I mean, we've been following your work for the last few weeks, and you've been talking about the respiratory protective equipment. You've been talking about fit testing, the importance about, why this is important to employers. there's obviously a lot of questions around this, and we'd love to hear about your presentations as well. I understand a lot of your team are dentists, and you have been doing this with them, Sami, Ashwin, Kat.
Not just dentists, we're a fully multi-disciplinary team.
Brilliant.
And I'll introduce them in a bit, but yes, can I share the...
Go for it completely now. I will leave it to your team, and I'm happy for you to start with your presentation. Thank you very much.
Perfect. Are we live? Are you able to see the screen?
Yes, we can see your screen. I'm sure people down there watching this, can you just type in and say, yes, you should be able to see the screen. Please do that pre-survey before we start this, but there we go. Go for it. Tarik, floor is over to you.
Just in case you didn't can access this, you can just shine your mobile or go to the survey. The survey essentially highlights the fact that we want to know what questions are out there. We want to know what questions you have about RPEs and what questions you have about fit testing. And we'll find out your confidence about these and help us make this webinar a bit better. I'll introduce my panel. To my right, there is Dr. Sami Darwish. Sami, can you hear us?
I can hear you.
Yeah, perfect. Yeah, so Sami is a long colleague, mentor, teacher, periodontist, oral surgeon, medical legal advisor, fit testing team coordinator, you name it. Wealth of experience, knowledge, and leadership to the whole team. We've got Kat on the right as well. Kat is a therapist, hygienist, fit tester, and again, manager and coordinator of the fit testing process that we've been doing. On my left, we've got Dr. Karim Al-Baghdadli, consultant anesthetist, editor, researcher, and I'll probably not be able to mention all the other things that Karim does. Can you hear us, Karim?
I can. Pleasure to be here.
And Kat, can you hear us? And can we hear you?
I can. Good evening.
Ashwin, GDP, clinical teacher, researcher, and fit tester on our evidence for today.
Good evening, guys. Hope everyone is well.
So,
can you guys hear me?
Perfect. Yeah, we can hear you nice and clear. So we've got a large team and an expanding team behind us. And as I said to Ashwin before, we've got leadership from Pepe Sherlow, LDN chair within London, to a multidisciplinary team of NHS and private GDPs, dentists, nurses, midwife, therapist, hygienist, practice manager. We've got a wealth of experience within our team, and we've all been fit testing together and gaining experience and helping in the way that we now can. So first of all, RPE, respiratory protective equipment. I don't want to mention or talk about why we need an RPE. Hopefully the picture says it, and no better person to give us a bit of indication why an RPE is needed, better than Karim, who's been using one for the last, or probably one of the first people in the UK to use one of these. Over to you, Karim.
Thanks very much, Tarik. Yeah, so as Tarik said, I've been dealing with COVID patients for the last 8 weeks, working frontline critical care, anesthesia, dealing with the sick patients, and I've got the battle scars, if everyone can see, to prove it here from constantly having my RPE on, my properly fit tested RPE, I should say. So why does this matter? Why does this matter to healthcare workers? Well, what's really interesting is that we're learning a lot about this disease. Everything that we're implementing and that we started implementing from early stage comes from our knowledge of the SARS outbreak. Now, in 2003, there was a huge SARS outbreak, and that was an H1N1. And the risk to healthcare workers was massive then. Now, the WHO reported in 2004 that about 21%, so 1 out of 5 healthcare workers, 1 out of 5 people that were infected were actually healthcare workers, okay? So a fifth of the population of people that actually had SARS were healthcare workers. Now that's a huge number. Now, when you go through, there were some areas and some locations at some places where this was actually a lot more significant. In Toronto, where actually I used to work, half. That's not an exaggeration. This is data that's published, and there's the citation down there. Half of people in the Greater Toronto area that had SARS were healthcare workers. Okay, half. And there's obviously lots of reasons for that, but what I'm trying to hammer home here is that healthcare workers are obviously susceptible and at risk. Well, okay, so that's SARS, and that's looking back, and that's not now, and that's a different disease. Yes, it is a different disease, but what do we currently know here and now? So what we currently know here and now with SARS-CoV-2 is, if Tarik can just move along, is we've got some early data. Now the data from China is not generalizable. I wouldn't encourage people to necessarily use that as representing what we know about the risks to healthcare workers globally, because the access to PPE is very different in China as it is elsewhere. And so we've got 2 studies now, and the citations are down there, and I'm happy to share the citations later as well. We've got 2 studies that have actually looked at the risks to healthcare workers. One's come from Italy, and one's come from Newcastle. Now, the Newcastle study was published in The Lancet just last week. And what they did is they swabbed a wide range of healthcare workers, 1,300 healthcare workers that work in their hospital. And what did they find? They found, again, very similar to SARS-CoV-1, is that about a fifth, up to a fifth of healthcare workers are actually infected. So that's a big number. Now, when you look at it like this, when you look at this example here that I'm showing you, I'm trying to demonstrate graphically what it means. But myself working on the front line, I've seen what it can do to people. I know that this is beyond numbers. This is real, this matters, this is people, these are lives. So what I wanted to just demonstrate is that actually 1/5 is actually the same as one of the 5 panel members. I crossed myself off because I didn't want to seem threatening to anyone else. But it's the same as one of us getting SARS-CoV-2 and therefore COVID probably. So I don't want to scare people about the risks of what's going to happen if you do get it. What I want to just emphasize is that the risks are there. They're very real, and there are potentially things that we can do about it. What are the risks to dentists? And in the dental setting, we really have very little information on that. We don't have very much information in the current healthcare crisis of what happens to dentists and in dental practices. So off the back of that, one thing that we've been doing is we've set up a national project where we're trying to capture as much information as possible, which includes information from dentists, to be able to work out what the risks of exposure have been so far. Now, we know that dentists have not been in practice for the last month or 2. But of course, we're trying to capture this information going back as far as possible. But even if we do have a proportion of dentists that have been exposed and that have got COVID, well, that's even before we've opened our doors. So once we open our doors and once we start treating patients well, I wouldn't say as we used to do, because of course everything will change, then the risks are likely to be amplified. So all I want to really emphasize is the risks to healthcare workers are there, they're present, they're real. And the best thing that we could do is to try and learn, prepare, protect ourselves, and understand and use PPE appropriately. So I hope that I've set the scene for you guys to be able to be super engaged with Tarik's next section. So I'll hand back over to Tarik to go through that.
Thank you, Karim. That definitely brings it home for us. We won't be able to survive without you, and dare I say, probably the country, if we had lost you, the country will not be in the shape it is now, for many reasons, but we'll leave that for another time. The hazards.
Come on, I'm going to give him a bigger clue than that. He works just opposite Westminster, St Thomas's Hospital. And I wonder who lives around that area.
So,
So I'll hand over to Tarik to keep going then, shall I?
hazard, risks, and effect. This is just to highlight that the virus, as you can see from the slide on the top, on the left-hand side, is one of the smallest hazards that we can potentially protect ourselves from. Definitely not something for the naked eye, not even through a microscope. And if you notice, that's even smaller than what the capability of the P3 filter would be. Well, how can that be if we're being asked P3? We all know that the virus will not be able to survive on its own. Thankfully, it can only survive within a droplet. And this is just to illustrate that compared to a magnified human hair, which what this long strand is supposed to demonstrate, and in comparison to a grain of sand, the droplet is small. It's not something that we would be able to feel. It's certainly not something that we'll be able to see. We just need to follow the science, and hopefully some of the evidence now that will be more generated within our sector will help us understand more about the droplets and the aerosols within our industry and sector especially. Main point for today is to differentiate between the respirators and the masks. The mask is a barrier, it's something that to protect you, to protect the patient from you, or the person in front of you from you, because it stops coughing, sneezing, it stops anything going forward. It also offers some filtration, but that's not its design. The mask is, the variety of it is either ear loop or hand tie. You may come variety of colors, but that's about it. We're well versed in putting one of those masks on. It's cheap, it's available, we know how to use it. Respirators, for most of us, is something new. Respirator is a respiratory protective equipment. It works by having a seal on the outside. The filtration capability of it is standardized. It goes through tests, it goes through a conformance assessment, and it adapts. They come in different designs, some that you've seen with an exit valve, some without. There are some disposable ones, there are some reusable ones. They come in different shapes and makes. And they're all different. It's not something that we're used to, something that we need training on. To get the maximum protection, we would need them to be ideally having an optimum seal and to be able to offer us the best protection. They're not available. They're more expensive. To use them, you have to justify it to yourself. You have to justify it to your line manager, to your employer. You have to justify it to the whole of the NHS and to the whole world, because everyone is after one of these and they're in short supply. There is some evidence that Ashvin will share with us about masks, respirators. Ashvin, over to you.
Okay, so there's a lot of debate at the moment whether a mask good enough, a respirator is good enough. We've all, like Tarik said, been using masks for a long time, and we've all either loved them or hate them, and so forth. Respirators is like another level of protection. What we always need to remember is that with the surgical masks, what were they intendally made for? Their design was to protect the patient. What we're now worried about is not about protecting the patient, is how can we protect ourselves from the virus? And there's a lot of research out there to show exactly how bad surgical masks are for filtration. So the classic one obviously is in the UK, the HSE, Health and Safety Executive, 2008. Obviously a lot of this research, like I said, is all based on either influenza research or SARS or MERS, rather than COVID specifically. But the HSE clearly said in 2008 that a surgical mask provides around a 6-fold reduction in exposure. By contrast, properly fitted respirators could provide at least a 100-fold reduction in exposure. And that, I think, pretty much sums up the difference in there. There's another interesting paper that someone put out was, what if you wear more than one surgical mask? What if you put, up to 5 surgical masks? And sadly, that so that it actually putting more masks on didn't actually do any effect. Or the other classic one is, do we put a surgical mask on top of the respirator? There's no evidence to say it does anything, but Again, we have to remember that what does a surgical mask do? It doesn't protect against the filtration from that point of view. So even if you're wearing that on top, it's not protecting the respirator. And what we're worried about is we're not worried about brick dust or particles, we're worried about a virus. And that's not something we can clean, not something we can disinfect off these respirators, especially as they are not fluid resistant. If they were fluid resistant, then all the people are talking about putting in an autoclave, all this kind of stuff. Sadly, we can't do that yet.
Perfect. Thank you, Ashwin. We will go through more evidence later, but as Ashwin said, we don't know. All we know, and what we'll bring you today, is principles and evidence, and hopefully with you will generate even more new knowledge. But nobody knows, but we have principle and we have guidance from authoritative bodies. So let's concentrate on the disposable respirators. So respirators can be close-fitting, they can be loose-fitting, they can be disposable, they can be reusable. Today we're going to mainly concentrate on disposable respirators. Because they're used in different environments, they're called single-use respirator, single-shift respirator. They're called a particulate respirator, a dust mask, paper mask. They're used by different people within different environments. They do the same thing. They filter particles. How do they do that? Is through having multiple layers of filtering material and mainly an electrostatic charge built in within them, which means if you wet it, if you try and disinfect it, if it gets soiled, it loses some of that capability. So it's not something that it's recommended. What we're faced with is which one is, even if we get convinced with the argument that, okay, I need one, it's for an AGP, I'm doing an AGP, I need an FFP3 mask, which one? Which make? Which design? You see people on the street walking around with different ones. As you can see from here, they come in different shapes and sizes. Even the same manufacturer could have on the bottom right a 3M FFP3 and Aura, and an FFP2 3M. One is cup designed, one is fold flat designed. There are some with adjustable straps, there are some with valves, there are some without valves. How do you make sure that you're getting the right one? Well, the key phrase to remember is adequate and suitable. And going through the presentation, we'll find out what it means and what information you need to find out, is it adequate and suitable? So the first thing is the filtration capabilities. We know that it's a particle, it's an airborne particle, it's a biological hazard, and we want to filtrate particles. So the first test is the classification of is it a P1, is it a P2, is it a P3? Essentially, this is an in vitro test through the filtering capability of the multiple layers, and a P3 basically assigned to a filter that filters out 99%, P2 94%, a P1 80%. WHO, NHS England, Public Health England support or deem adequate a P3 or a P2 as being adequate. The Health Safety Executive is on the stance that you should use the highest protection available to you, which then puts it into the P3 ground. However, it's also acceptable or adequate to use a P2 if you cannot have a P3 available to you. Again, Ashwin will give us some evidence to navigate through P2, P3. Ashwin? Can't hear you, Ashwin.
Hello, can you hear me?
Yeah, can hear you now.
Okay. What I always think, it was always good to look back to is what did we do before COVID, before the panic? And I went back and looked at what did Public Health England say beforehand. So in 2016, in the infection control precautions, for minimizing transmission of acute infections in healthcare settings, it clearly says for all AGPs, an FFP3 respirator, fluid repellent gown, gloves, eye protection, blah, 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 needs to be used. And there's a legal requirement for any healthcare worker to wear an FFP3 respirator, and that it should have undertaken a respiratory fit testing prior to using it. Respiratory testing should be repeated regularly, and whenever a need is justified, which we'll go into in a bit more later. And that was what the stance was in 2016. Now, tracking forward, obviously now they have said that it's okay to use FFP2 and FFP3, and they did a rapid look at the evidence, which was released last month, and they have said that ideally, this is obviously the health safety executive, they said about the equivalent of N95 and FFP2. N95 is an American WHO standard, not a European. FFP2, FFP3, this is looking at our European standards. And as you can see on the screen there, you're looking at the differences in filtration. So a P1 is 80% filtration, P2 is 94%, and a P3 is at least, as I said, 99% with less than 2% leakage. And what they've said is that the WHO goes by the N95 FFP2 standard. Even the WHO does admit that there's very low evidence for any of these things, but these are what are deemed as standard practices with the limited knowledge that they do. And I suppose the most reason why, because it is very hard to do randomized control studies on saying, does one mask work better than the other one? Because how do you justify giving someone less protection than you could give them? And so that's what they've done. The difference obviously is in their testing. The European standards test against salt and oil, whereas the N95 is only testing against salt particles. So there's difference in the testing and also in how rigorous their testing is. However, that's why the WHO stance is that FFP2 is equivalent to N95. And so that's where the new guidelines have come in, saying that ideally FFP3 is our gold standard. However, the WHO have said that N95 FFP2 is adequate.
Perfect. Thanks, Ashfin. So part of adequacy is the filtration capability. In healthcare, it seems logical to have a disposable PPE, especially when you're dealing with a highly contagious biological hazard. So being a disposable or an FFP3 seems to be the go-to, and that's been essentially the initial stance. Other things is being CE marked. That gives you a quality reassurance that it's gone through a conformity assessment, and the British standard is 149/2001, and obviously P being for particles. To note that there is a clause within the European standards that if it doesn't have to, they've made allowance for the FFP3 not to have CE marking, which is available on HSE website. However, there are some certain parameters to meet, if you like. One is that it's being that FFP3 is being procured from an official channel that's perhaps been done within the country, and that's specific for COVID-19 response. So if there's a factory in the UK that's able to produce FFP3 and they've done their internal testing and the government is happy with that and gives it to practices, that's still okay to use. So it has to come through the official channels and has to fulfill certain criteria. However, it doesn't mean that you buy something off the net and expect it that it says FFP3 without CE marking, without the British standard, and expect it to be okay and legal to use. Again, part of fit testing and involving an expert fit tester or an accredited fit tester is informing you how to select your RPE and ensuring or helping navigate the suitability and adequacy. And it's something that we will go through. Like anything, we should read instructions or the manufacturer's instructions, and most of these products, it will say the product does not eliminate any risk of contracting the disease. So on its own, it doesn't. And HSE recommend that it's used as a last resort together with everything else that we do. And as Drew highlighted earlier, we have many things that we need to consider within our flow, and it's something that Sami will cover later on as well. But essentially within our PPE, we have basic, enhanced, we have guidance on how to don it, and more importantly, or most importantly, how to doff it correctly. There are certain things in dentistry that we're used to. Some of us are used to putting gowns and taking them off. Although previously we were concerned to do it in a sterile way, now we're more concerned to do it in a way that protects us. There are things that are recommended, like a coverall, which we're not used to. All of this we need to be trained in. We need to reassess how we use it. We need to have dedicated area in doing it, and do it as a team as well, and evolve how we're doing it. The main subject from today, or the main awareness that we want to raise in, is why fit testing is required. You don't expect to buy a hat and it has the same fit to your child or to your colleague. You don't expect to buy different pair of jeans from the same manufacturer, or the same different designs from different manufacturers, and expect them to fit the same. You have to try them before you convince yourself and buy another 2 of the same design. You'll have to wear it. You'll have to challenge it and see, can you work with it? Can you do whatever you want to do with it? Same with trainers or anything. The fit, although it's standardized, and with RPEs, they're not. They have different makes, different designs. The manufacturing process is different. So we need fit testing to see, is it suitable for us? Is it suitable for our facial features? And that's essentially what fit testing is adequacy. We know, we can assess, we can see the conformance of the product, but fit testing is to see, is it suitable to you, to your facial features? So the terms to be aware of is fit checking and fit testing. Fit testing is what it says, is testing the seal around the mask. There are different ways of fit testing. There are qualitative, quantitative. There is a way that, and quantitative, there are different methods or scientific methods to do it. And they've been standardized and accepted within HSE. Fit testing is the responsibility of the employer. It's done one for that model and ensures that it is suitable for you or not. Fit checking, on the other hand, is the responsibility of the wearer. And through the fit testing process, you should be educated on how to don the respirator correctly, consistently, and how to do the fit check every time you do that process. And there are different for reusable respirators, that they're different for each make. For disposable respirators, they're the same thing. And in a bit, we will do a demonstrating for you. Ashvin, do you want to give us some evidence on fit testing, fit checking, anything to consider?
Of course. So firstly, about the different tests for fit testing, the Occupational Safety and Health Administration, there's actually quite a few different tests you can do. The qualitative is the one we generally tend to do, which is the one we will demonstrate later. And there's different types of solutions that you can do. There's an acetate protocol, there's a sweet protocol, a bitter protocol, and using smoke. Quantitative is obviously in the name quantitative, where you get a number, whereas qualitative, you just get either a yes or a no. Quantitative, there's different ways. There's a generated aerosol quantitative fit testing. There's ambient aerosol condensation nuclei counting machines. There's controlled negative pressure machines, and so forth. So those are all the different ways that this can be tested. The HSE did a nice review of this. Literally last year, 2019, there's a review of fit test pass criteria for FFP3 respirators, and they tested 4 methods, qualitative and quantitative, and their conclusion was that the Bitrex qualitative fit test has been shown to give a good determination of the fit, and that it may give potential to give the most accurate determination of true fit, as the problem with the quantitative ones is you have to make a hole in the respirator to get a reading of inside and outside. However, there is obviously limitations with any qualitative, in the sense that you're relying on the patient or the wearer to give an accurate response. And there have been certain papers where they're saying, with placebos, can placebo people taste it, and so forth. So there's pros and cons for all the different ways. In America, the quantitative is, I think, the gold standard. But in the UK, with the HSE, the qualitative Bitrex fit test, which is the one most commonly in we do, has been shown to be given the good determination of the fit. There's lots of studies where people have just been saying that a fit check is okay without doing a fit test. And a lot of people, when I've been asking fellow colleagues, not naming anyone in particular, where certain organizations have taken the stance that it's okay to do away with the fit testing procedure and just give education and fit checking. The evidence also fit checking is very important. And also that giving the education, just by giving education can improve the fit testing results. However, they don't, just doing the fit check on its own is not enough. And people who have been wearing respirators for a long time, for example, there's a paper looking at pharmaceutical companies, wearers, and they found that the fit, even though they've been wearing the respirators for a long time, I think up to over 50% of people would then fail the fit test. And that's even on people who are well used to wearing these respirators.
On the other hand, if that same paper quotes, if you fit test a group that have passed a fit test, around 93% will pass again. So that tells you the fit testing process is not 100%. The fit checking process is not 100%. But according to guidance, fit testing improves the quality of your seal, and it's the guidance of the standard operating procedure, essentially from health safety executive. We don't know what the consequences of all these things. All we know and all we can highlight is principles and official guidance. Before I go to some of the procedure, what we found as well is dentists and dental care professionals are probably well suited at doing the fit testing process. A couple of things. We're used to assessing the lower mid face. We are essentially, with a qualitative test, we're doing a taste test. So we know what can alter taste. We know what limitations some people have in taste, and it helps us interpreting the results of the fit test. So we found that knowledge useful, and it empowered us to ensure that the process is well done. Also, we're professionals. We have a duty of care. We're conscientious. We have a lot of qualities that allow us to be good fit testers, I believe.
One of the other key papers, if I might just add in, about the use of the user seal, I've just brought up here from 2011 about healthcare workers and respiratory protection. Is the user seal check a surrogate for respiratory fit testing? They had over 600 people doing it, and of the 784 subjects in that population, 90% indicated that they felt they had an appropriate face seal after completing the user seal check. However, after doing the respiratory fit tests, they had failure rates of up to 30%, as high as 30%, which then obviously demonstrate how important fit testing really is.
So, can we see Kat in the panel? Drew, can you split screen, or I'd like the audience to be able to see Kat.
It's okay. I will just do some settings. If you bear with me, we will just need to stop the screen share for a moment so that we can do that. Okay, excellent. Yes, we can see Kat now. We will, and excellent. Okay, we're good to go, Kat.
So an important aspect of the mask is, or putting the mask, donning the mask is an important aspect of the fit testing process. And Kat is an expert at donning and an expert at demonstrating and teaching people, and would be the best person to suit it. Kat, take it away.
Thanks, Tarik. So initially, what we want to do is make sure that you take I've got a disposable respirator here, and this is probably one of the most common ones that we've been fit checking, fit testing. And firstly, you want to make sure, I'm going to take that right up to the camera, that you can see the brand and model number, because a lot of them look the same, but are actually different. So you need to make sure that this is the exact brand, exact model number. It's got its British Standard stamp on it, that you've been fit checked and fit tested for and passed for. You're going to take that out of the packaging and then just double check that it's not been tampered with in any way. So you need to make sure that the elastics are patent, they're not broken in any way. It looks new, it looks clean, and that you are ready to start your working session day. Then you're going to open up the respirator. And what we want to do is cup that in your hand, and then just see that the foam section at the top, that is the top section that goes over your nose. Make sure that your elastics are on the outside, and then you're going to cup that over your face. I'm going to let you take over, Tarik.
Yeah, perfect. So Kat now, as you can see, doesn't have earrings on. Her hair is tied up. Once the respirator is on in the right way, she's putting the top elastic on and then the bottom elastic on. I'm going to be your buddy today, Kat. Kat is going to do a horizontal spread of the respirator. She's going to do a vertical spread of the respirator to get as much coverage as possible. And she's going to check that the elastics are nice and flat, that they're not covering her. There's no hair between her, it's on the skin. And on the top elastic is getting the most stretch on the top of her skull. Yeah, that looks well. It's positioned in the right way. It's not too high up, too low down. If it's too high up, you're going to lose some surface area coverage. If it's too high up, too low down, then you're going to, when you adapt it, you're going to pinch your nostrils. So Kat now is going to adapt it. She's using 2 fingers. She's pressing down firmly. She's putting the fingers towards her face rather than towards each other. She's putting really firm pressure to make sure that they are nicely adapted. How does that feel, Kat?
Perfect.
Comfortable? Can you wear that and it's comfortable to breathe with?
For about an hour.
Yeah, perfect. Okay, good. And that's essentially and do you think you'll be able to put that on correctly, consistently in the same way that I've demonstrated to you now, or you've demonstrated to us? Yeah, perfect. So the manufacturers say if the person gets distressed, difficult to breathe, if the respirator gets contaminated, if they feel dizzy, if it's damaged in any way, if it gets soiled, it should be removed. And we know in our environment, it should be removed in a different way. However, before Kat uses the respirator, she will do the fit check. So the fit check, she's going to put her hands over the mask. She's not putting pressure onto the respirator. She's just gently putting her hands on top. She's then going to do a negative pressure check. So that's inhaling forcefully. And essentially what she'll be able to notice that the respirator is slightly collapsing on her face. And that tells you that it's got a nice seal or likely to have a nice seal around it. She's then going to do a positive pressure check by blowing constantly through the respirator. And that does 2 things. Kat, can you notice any air coming on the top, any air coming from the bottom? No. And when you were doing it, where did you notice the air coming out from?
Just from here.
Perfect. And that tells you that the valve is working and that air is exhaled from there and it's working properly. Now Kat can do her procedure, and because she's been to the loo, because she's well hydrated, because she blew her nose before doing all this, unlikely she will need to interfere with the respirator, and she has a good chance of it working. And before your fit test, those are the steps that you will do before you go on. So now we're going to demonstrate to you how to doff it or how to remove it. Again, as Karim highlighted before, and as all of us highlight, and Ashvin in his evidence, one of the most important parts. So we usually, or what's indicated is to do this in your doffing area, which is separate area from your aerosol procedure. It's usually the last thing that's removed. Glasses off, hands clean. We advocate a non-touch technique. So the bottom elastic comes out first, top elastic comes out, gently off. She's leaning forward, closing her eyes, holding her breath, and dropping the mask in no-touch technique. throughout her use of the respirator, she did not remove it up. She did not put it down. It's off her face in the bin. She used it for the least amount possible, and she did it in a non-touch technique. So probably the safest way possible, and she cleaned her hands afterwards. Thank you, Kat. Drew, if you can bring us back to the presentation. Do I need to share it again?
Yes, please, if you share your screen again. Yeah.
Another things to highlight on the packaging, it says that this respirator should not be modified or repaired. So essentially, you should put it as the manufacturer's instruction. And if you go to YouTube and type in 3M fitting instructions, you will get the manufacturer's fitting instructions for these respirators. And most of them follow the same as what we've demonstrated today. If you cross the elastics, maybe it is a modification. If you put something on top, maybe it is a modification. The whole point of non-modifying is you don't want to do something that will reduce the risk or increase the risk of you not being able to do the same process consistently, correctly. So we've got adequate and suitable, we've got consistent and correctly as phrases to be aware of or take forward. Hope that's clear. If we can go back to Ashvin, please, Drew.
Yep, Ashwin. Yes, we have his video ready. Ashwin, are you there? Excellent. Yeah.
Okay.
Can we see Ashvin?
Do you want to?
Yes,
Tarik, do you want to stop sharing your screen?
I will do that. There we go. Okay.
Ah, great. Okay. So I've got two different types of reusable examples of reusable mask here. This is a JSP medium size. This is a Corpo small. You can see some similarities in the design. They're all silicone rather than obviously fabric. They've got filters on the sides, different types of filters. They all have exhalation valves in the middle as well. And they've got different contraptions to help you put them on. So I'll give you an example of JSP because fits me better, purely for that reason. First, obviously, take my glasses off because otherwise it's impossible to get on. Then we have our head.
Also, Ashvin, when did you last shave?
This morning.
Perfect. So ideally, it should be at the start of the shift. Facial hair is a controversial subject, and we will have some guidance on it later, perhaps. But essentially, for a male person, ideally fully clean shaven. There are some COVID or respirator-friendly designs of facial hair. The glasses are off, and then the respirator is on.
Also, to the evidence of clean shaven, before I forget, there's lots of articles, a systematic review of like 14 reviews of wear, and they also, apart from two, I think, all of them showed that having not being clean shaven had a massive effect on the seal. And the HSC did a good study a couple of years ago where they said just after even 1 day of not shaving would impact up, you would lose the seal. And if you're losing the seal, my classic phrase is the seal is a deal. And the air will take the path of least resistance. So you can have all these fancy filters, but if you haven't got your adequate seal, it's not going to work. So back to this. So I normally cup it in my hand. I've got my top strap here. I'll put it on there. I've got a clasp.
I'll take over, Ashvin. So there are different makes. Each one is different. This being a reusable respirator, again, manufacturer has recommendation of putting it on. Once Ashvin puts it on, he will need to adjust it. Again, not modify it in any way. This particular make is adjusted in this way, a head part and a neck part. And this has each, before doing that, Ashvin, if you can demonstrate to us a fit check, please. So with this one, it's pressed. And once it's pressed, Ashvin is gonna inhale in and hold his breath. And you can see that he's maintaining a seal within the respirator. It's not the easiest thing to do, and it's not the pleasant thing to do, but it gives you a visual representation that you're likely to have a negative and a positive pressure check. Then Ashwin would put his glasses on and also his PPE on, and usually do the same thing. And if Kat was wearing glasses or wears spectacles, she will do the same thing. And if the glasses are steaming up, it's a poor indication of the mask being not correctly put on. Is that comfortable for you to wear, Ashwin?
Just about.
Yeah. How long do you think you can maintain it for?
Not too long.
Perfect. Give me an indication roughly.
I'd say the sooner I could get it off, the happier I'd be. But
Would
I'd
that
say
be-
after,
Yeah.
but I'd say half an hour to an hour.
Perfect. Okay, good. That's good enough for.
Come and join me in the hospital. You'll wear it for much, much longer than that half an hour.
Yeah. And you'll start showing the battle signs, obviously.
I can imagine.
So things to take into consideration that different respirators have different comfort levels. Different respirators allow different ergonomics of work and needs to be taken into consideration. We all have different abilities, and those are the things that you need to consider when doing a fit testing process. Is it comfortable for me to work? Is it appropriate for me in my setting? Would it allow me to do the job safely and offer me the protection that I would? Thank you, Ashwin. Again, if we can go back to the presentation, please, Drew.
If you
Or-
share
no,
the
that's
screen,
me.
you
Yeah,
do
yeah,
the share
sorry.
screen.
Are we back on?
Yes, you're okay to continue.
Perfect. So, fit testing process. Kat, do you want to take it over, please?
Absolutely, thank you very much. So what we'll do is initially we would take a sensitivity test of each individual that we're testing. The idea is that we need to see what levels they can taste, because it is essentially a taste test. We'll check them with their RPE, so as you saw, the disposable or the reusable respirators, and we'll ask these questions. Are you confident to wear it? Is it comfortable? Do you think you could work with it? Can we try that on with your other PPE, such as your visors or your loops, your own spectacles? And we'll just double check that that person is actually able to utilize that RPE before we start the test. And then we're going to put them into a dosing hood. And the dosing hood is essentially to keep an aerosol around that respirator for the duration of the checks, so that we can see if that person can taste at any time. And what we'll ask them to do is to keep their mouth open and their tongue slightly forwards over the bottom teeth while we dose. I don't know if you can see me, but we dose with a little nebulizer like this one, and it has a solution in it that tastes a certain way. During the test, what we'll ask them to do is keep their mouth open, and for the first 60 seconds, just breathe normally. And the whole time letting us know of any time they can taste. After that, it's a deep breathing exercise, so some nice heaving breaths. And we want to see if when we're testing that respirator to its limits, it's actually performing well. So as deep as they can go for the next 60 seconds. After that, we're going to ask them to do a head side to side motion. And that's right to the side and taking a breath when they get to the side that they, as far as they can go. The next one is a head up and down motion, so not leaning right back.
Do you want to split the screen?
If you're okay to do that, I think that'd be great.
I'm all ready.
Drew, can you split the screen between Ashwin and Kat, please?
Yes, it is. It is split.
That is great, Ashwin. Thank you.
Tarik, I think you need to stop sharing the screen.
Yeah, the controls are with Drew.
Thank you. You're in your head. Thank you so much, Ashwin. Looking good. So we were up to head side to side. So we'd ask Ashwin to open his mouth, tongue slightly forwards. Obviously, he would have his respirator on at this point, so we wouldn't be able to see that. We'd have to trust him. And we'd ask him to move his head to the side and take a deep breath at the extremity, and then move all the way to the other side and take a deep breath when he's there. And we do that exercise for 60 seconds as well. After that, we do the head up and down exercise. So we're asking them to not lean back, but as far as they can go, comfortably, and we're trying to replicate movements that they might do within surgery and when they're treating their patients. After that, we're going to pass them a passage that's called a rainbow passage. It's just a standardized sentence or paragraph that gets you saying every word, every syllable, every movement that your mouth could say, again, trying to test the limits of that respirator. After that,
Pot of gold and something like that.
That's correct. It goes on and on.
At the end of the rainbow.
And we all enjoy listening to it over and over. The next exercise after that is a bending forward exercise, and we ask the testee to bend at the hips 90 degrees. Thank you very much, Ashwin. And what the whole time, mouth open, breathing again slightly over the tongue to double check that they cannot taste. There's no inward leakage into those respirators that we're testing. At the very end, we ask the subject to breathe normally, so mouth open still, tongue slightly forwards. And what we will do is then continue dosing the hood throughout this, this test, so that the level of aerosol is at the highest point it possibly could be throughout. And at the end of the test, if they haven't tasted while the respirator has a full seal, then we would suggest that that's a pass. We do a breach test towards the end, and Ashwin's very kindly getting his hand ready to have the respirator on. We pull that respirator away and see if they have a reaction, and that is exactly the reaction that we're aiming for. A nice full mouthful of eucalyptus, which is that same taste that you paint on children's fingernails to stop them chewing. It's lovely. And at the end of the test, if they haven't tasted until they've breached the seal, then we know that they've passed, and that respirator, the specific brand and style respirator that we've used on them, is good to go, good to work for AGPs.
Thank
Do we
you,
want to
Kat.
go back to our presentation?
So, are we back on with the
Just the next slide, please.
slides?
Yes, we're back on slides and we can see you as well.
Perfect. So, Kat, if you can take us through the report.
So what we need to do is, obviously we write a report saying that this respirator is right for that person, and that report does last for 2 years. However, there are multiple things that could change that would mean that we would need to refit test that individual. So Tarik's kind of listed out here a few of those reasons. So a loss or gain of significantly in weight, molds in the mask sealing zone, or any other changes in that area, like scars, plastic surgery, if you break your nose or your jaw, if you suddenly get some deep wrinkles or have significant dental work, if it's been 2 years, or most importantly, if you get a different supply of RPE. So we, as I touched on earlier, we have been mainly fit checking, fit testing 3M1873V, but very similar to this is the Aurora, which we've also done, and also the 8833, which is also being supplied in this area. We've also seen a few different masks that are like so. So if you receive a different shipment, if it's got a different number on it, you can't just automatically assume that it's going to give you a good seal. We need to refit check, refit test every single time that that changes.
Perfect.
You know, the one thing I forgot is that if you change your glasses as well. It's the one thing that's not on there. I know I'll get told off for not saying it.
And you can see there is detail in the, the detail is important. And the only dental relevance that we found in fit testing or fit testing procedures says significant dental work will need a refit test. We probably all know that significant could be just removing one tooth, and that would be a strategic tooth can be significant enough. So we definitely have dental knowledge that we can apply in this field, and we are well suited as a workforce, a multidisciplinary workforce, to take this forward, definitely within our profession. There are different terms that we need to make this whole area confusing. What is single use? Single use in PHE or NHS England terms is single procedure or single AGP, it becomes single use. It's a disposable item, at least for the disposable RPEs. Less than an hour is what the health safety executive expect a person to wear it comfortably. Single shift is probably what a builder would call, or somebody in the construction industry, because they're able to put it up and down. They're not dealing with a biological hazard. 8 hours is what the manufacturer would say to expect the disposable respirator to work within a dusty environment, because they're concerned about the respirator clogging up because they're dealing with dust and other particulates. Definitely off the face in the bin, and definitely a non-touch technique, because we're dealing with a biological, the highly infectious hazard. It's part of health and safety at work and COSH 1974, and the employee has certain duties to be reasonable, to cooperate, to not interfere with anything intended for health and safety. As Kat said earlier, it's the wearer and the employer's responsibility to keep that record, and that's whether it's a pass or a fail within their HR file, and to retest within in 2 years, or any of the conditions that Kat has mentioned. Or sometimes we've had people that are not confident. They've worked with it and they think, oh, I'm not confident in wearing it. We've had people that think, oh, I can still smell something. Well, smell is not an issue, because for most, smell is a vapor, and this RPE protects you against particles, not vapor. So you can still smell things, and that would be okay. But I would always want the wearer to be confident and comfortable in the RPE that they're wearing. There is the Public Health England and multi NHS, all of different agencies have come together and produced nice guidance. And in these difficult times, under these difficult circumstances, without having all the evidence at hand, they've produced nice guidance and very helpful guidance. And it's all collated together within NHS website, very accessible. But this is a multi-setting guidance. It is for multiple disciplines. We all need to have our local risk assessment, and the wearer, the employer, and the local organization is the expert, with the help of other providers in the areas, with the help of other urgent dental care centers, working collaboratively all together. We will ensure that we have a safe working environment and a good team take it together. There has been an amazing community spirit within the area that we're working, come together from everyone involved, and that collaborative approach made working environment safer and going back to work a lot safer, easier. And we've managed to interpret this national guidance to make it work for us within dentistry, within our own teams. And we're open for it to be evolving process, because the evidence is growing, and we have to keep up with the data, with the information as it goes forward. The next period is basically, or the next chapter is for Sami to take us through. Sami, are you with us?
I am, yes.
Perfect. So Sami, if you take us through on the global things that Drew alluded to, and how can we prepare as a team and as a organization within our own environments?
So I actually, yeah, I've got the graveyard shift by the looks of things. But I hadn't seen Drew's lovely presentation before, and I think he hadn't seen mine. So there's going to be a little bit of changeover here. But basically, this is what we're used to looking like. Here's my lovely wife, and she's not wearing an apron, but she's pretty clued up there, I think. Maybe she should have taken her watch off. But as you see, she's working very close to the patient, and this is what we used to look like. And I think this may well still be appropriate for non-AGPs, although some are arguing that you know, what are AGPs exactly, and should we be calling them aerosol generating exposures by merely being next to the patient? So the next is what we're going to start looking like into the future, I think, and this is going to be more like the appearance of the commonplace dentist, particularly with the AGP. So hat, gown, apron, respirator, visor, all in there. So, but we're not quite at this level yet, which is Kareem modelling the full respirator hood. Although, who knows? But we're not here yet, thankfully. So I think there's going to be a lot of crossover with what Drew had already talked about here. But so how can we change our practice? A few just clues and tips as I see them anyway. So with a view to trying to limit the exposure of the patient to you and you to the patient and the whole clinical episode, reducing the time that the episode takes is reducing the risk. So teledentistry has become more commonplace in the last month or so, hasn't it? Much more than it has. We were routinely using it previously. So we've been using it for our AAA protocol for the last 6 weeks or so, and that may actually become more of a common practice. But it would be sensible, as I see it, to gather as much information as possible before the clinical exposure. So because it minimizes times with the patient, and actually that bit of triage may negate the need for the dental visit, depending on the information that is picked up. So I do advocate the use of teledentistry even after the dental practices are open again. Next slide, please. So now, before the appointment itself, a pre-appointment phone call is quite useful as well as a bit of a filter, and just trying to pick up if the patient could potentially be COVID positive. So some very generic questions on have they had any symptoms, have they had any fever, also picking up any changes in their dental concerns, as in the reasons that they're coming. Is it still hurting? Any changes in their domestic setup, which basically means has somebody in their household had COVID, or has somebody in their household had become a vulnerable individual. Next slide, please. Now, our appointment structures are definitely going to have to change, aren't they? So staggered appointment times are going to become more commonplace, and definitely longer appointment times to account for the clinical procedure, as well as everything else that goes with it, such as the donning and doffing procedure, such as the wearing and fitting of the respirator, such as the wiping down and mopping up. And of course, if there is an AGP, we are now in a position where we have to consider how long downtime is needed after the end of the procedure before another patient comes in. And I've heard different things. I mean, I think, you know, the guidance at the moment, or at least the UDCs in London, what we've been told is an hour after an AGP. But I mean, Ashvin was mentioning earlier, and he may come in again if he likes, that the publications have been reporting different numbers here, haven't they? I mean, I've heard up to 3 hours that the aerosol is still in the air and circulating. So that's something that we have to consider. Next slide, please. So it'd be quite useful to have some of the episodes being carried out even outside the practice. So when the patient turns up, as is traditional, they walk through the door and they turn up at the reception desk and tell the receptionist that they've arrived. Well, how about a different technique is that they arrive and they call you up from the car and they say, hi, I've arrived. So that means the staff can log your arrival, but basically stay in the car. This sign was a very useful sign that was made by one of my colleagues, Peter, from the first principle, and it just warns patients that if they are in any way COVID positive or suspect so, they just must not enter the clinical environment. So a sign at the door is particularly important. But the ethos here is to try and stop people mixing as much as possible. So if we don't have use of a waiting room, that would be ideal. The other things that could happen in the car on the phone is any questionnaires that they were going to do, the type of thing that we are accustomed to doing in the waiting room, filling the questionnaires, filling in the medical history form, and data collection as such, can be done in the car. One may even consider taking advanced payment, and that would mean that when the clinical episode is finished, then at least they can just leave the building straight away. So, and then on the phone as well, they can just confirm that they haven't been felt, that's a typo, confirm that they haven't felt unwell. Okay, so the next slide, please. So when they come into the surgery, it might be prudent to take their temperature straight away. So we might have one of these runner nurses who is there to coordinate the pathway for the patient. We could offer them a mask to wear. We could ask them to have hand sanitizer, which would be immediately available at the reception bay there. We could even potentially ask them to put gloves on, wash their hands, give them shoe covers, and this can all be coordinated by a welcoming healthcare professional on entry. Next slide, please. Now, with the waiting room, we must now try and really think about social distancing measures. This is the waiting room of a good friend of mine, Moena, where the previous waiting rooms, there was quite a few chairs there, and then we separated all the chairs from the centre and put all the chairs spaced apart, 2 meters apart. The patients don't face each other at all costs, trying to avoid escorts coming in, although some people may need people coming in with them. All the other stuff that we used to have in waiting rooms, magazines, coffee cups, things that can be touched, remove them all. And ideally not to have a waiting room in use at all. So if they can stay in the car or outside or somewhere else, brilliant. But the waiting room is if required. Next slide, please. Now then we can start thinking about social distancing when we're actually working as well. So, whereas we used to be sitting right next to the patient while talking to them, offering much more empathy than is presented in this picture, but one might consider actually standing from a distance while talking to the patient. New habits, new culture. Next slide, please. And I, in our organisation, actually most of our admin staff are not at the reception downstairs, so they're not front facing anyway. Most of our bookings happen from upstairs. The staff have their own phones and computers somewhere else, and that's where they phone up the patients, book the patients in. They've got their computers there, and I think we need to try and carefully consider what is it that needs to be patient facing, and anything that really doesn't, just remove it, and if possible, with the structure of the way the building is set up, depends how big or small the practice is, to have them from a distance. But then these are a new thing that now that we have to consider, aren't they? So having reception shields at the desk to protect. Well, to protect the receptionist, but one may also say protect anyone who's either side of it. Now, our practical measures need changing, don't they? I'm not sure if our cleaning surface techniques do need to be changed because they're supposed to be that good. But at least I think demonstrating it to patients in a more visible way is the a way of actually gathering their trust in us. So even being seen to be cleaning them, mopping the floors, and then these other devices that I know have been talked about. In my personal opinion, I think it's high time that hygienists have nurses. I mean, I've thought that for a long time anyway as a periodontist, but now, particularly with the use of ultrasonic scaling, I think personally this is very important. And one may also think of ways of having the patient walk through the building. I mean, some clinics have different doorways. So do you want to have an entrance for a patient, then they go out the back door? It's things to consider within your own environment. Next slide, please. So one may also think about now adjusting their clinical technique. So what is dentistry going to be looking like? I don't know. We need to maintain a core service at least, but we have no idea where we're going, and we will have to wait to see how we as a profession develop. But the ongoing debate about AGPs, and I know there's strong opinion on either side as to whether AGPs are going to be relevant to our profession or not. I mean, we have to follow the science, and we'll see what evidence comes, and we'll interpret the evidence or the lack of in whichever way it presents to us. It may not be that AGPs become a problem, but we have to monitor that as we develop. So other things that can be adjusted are your mouthwash. There is some evidence to say oxidizing mouthwash may help. Are we going to start using hand scalers much more than we are ultrasonic and perio? I'm not looking forward to that. And the use of rubber dam isolation. I mean, I'm certainly going to start taking out all my deeply impacted wisdom teeth under rubber dam from now on. Next slide, please. So, and then my background's law and ethics and sociology. So yeah, I just thought I'd just touch a little bit on the ethical aspects of fit testing. And this is a bit of a personal opinion, really. I'm not particularly advocating anything. So if you go onto the slide. So, I mean, we've been doing some fit testing, but at the moment we've been doing it to the UDCs only. And that's arranged through the local area team. We've not been making ourselves available to other people, practices, but inevitably people are reaching out. We've got no problem communicating with colleagues, but we're not going to be fit testing closed practices. First of all, because you've all got to be in your homes. That's going to be breaking lockdown rules anyway. It does encourage non-essential travel, and it's encouraging dental practices to go and buy PPE where it really shouldn't be inside a closed practice, and stockpiling of supplies. So that's not to say we're rejecting anyone, but and we will be there to help anybody that reaches out for our help, but we are ethically considering that to be at the right time. So I want us all together as a profession to consider the health and well-being of society at large whilst we carry out this project. And really, I'm just trying to encourage people, don't go and buy a load of respirators, please don't, because Karim and his colleagues need them in the hospital. And if we're not practicing clinical dentistry, we don't need them just yet. Now, the other thing is, can you just go back there? So the other thing is, when you do come to buy respirators, don't go and buy a pack of 200 before you're fit tested, because if you fail the test for that respirator, then you're not going to be able to use that box. So what we suggest is maybe you buy a small stock of 5 or 10 or whatever that come in the box, use them for fit testing members of the team, and only when your fit test has been passed, then you know which one you're going to buy, and then you can go and buy your stock. Next slide, please. But of course, just be careful what you are buying, because there's some funny old stuff out there, but that's been alluded to in some of the previous slides. Next slide.
Can I just add there, Sammy, about the stockpiling and thing there? There's a lot of evidence out there to show that a lot of these masks don't fit everybody. And classically, there's a lot of studies, obviously, in the Far East, in China, Korea, where they've done lots of anthropological studies showing that we all have different types of faces, different sizes, everything. And that for some, from certain models, up to only less than 10% were fitting certain people. And that's to do with ethnicities and also gender. So between males, and there's lots of studies saying that a lot of respirators fit males better than females. So you have to be careful in making sure that, like Sam was saying, we don't want to be buying loads of one respirators when they won't fit.
So to use the analogy that Tarik was...
add as well, that's certainly been our experience. And through fit testing process, the better the variety of respirators are, the better higher chances of passing rate you're gonna get. So that's another reason for not getting respirators, and using the fit testing service to empower you with the knowledge into, again, what's adequate, what's suitable for you to then proceed with. And we don't know if we're gonna go forward with FFP3s or not. We are now within a high peak of a pandemic. Routine dentistry is different to pandemic dentistry. So pandemic dentistry at the moment is FFP3. We don't know what's around the corner.
So just as I've only got a couple more slides left, but I just want to touch that message home really well. I mean, one of the analogies that you alluded to earlier, Tarik, was about buying a pair of jeans. So if you're a size 12 in Marks and Spencer's, you can go and try your jeans in Marks and Spencer's. Actually, you find that those size 12s don't really fit very well. But then you go across the road and you go into Gap and you go for a size 12 there, and actually the Gap jeans fit you much better. So that's two different make of jeans, i.e. mask, same size, but one fits you better than the other. Now, what you wouldn't do, say you needed a pair of jeans for each day of the week, you wouldn't go and buy 7 pair of jeans from Gap until you've tried them on. Try them on, check that they fit, and then when they do, buy the 7. So don't stockpile the masks until then. So just back to ethics a little bit more. There has to be some level of prioritization. So in this pandemic crisis, we have had guidance that really the patients should be managed by the most senior clinicians. And so the fit testing needs to be allocated in line with that. But there are also the non-clinical staff that may also need it, and that has to be considered appropriately. But the more exposure, the higher the priority. Next slide.
If I can add to that, we're all cognizant of the limited supplies and changing supplies. So putting the whole team through fit testing may mean that you run out of supplies. So at the moment, we strategically do our fit testing so that the service is up and running, but not necessarily the whole point of it is everyone in the team is fit tested. Because funny enough, we all think that AGPs, or most of dentistry is AGPs, in urgent dental care. Surprisingly, AGPs are not the majority of procedures. So the workforce that need to be wearing the respiratory protective equipment is not as many as they non-AGP. And to reduce the wastage, the way that we've dealt with it is use our dental knowledge, develop novel techniques of measurements, scanning, and looking at our data and analyzing our data to reduce that factor of wastage before actually we embark on the fit testing process.
So, couple more just things on your ethical considerations. Just remember that our workforce also have their own personal situations. So, you know, they could have vulnerable members of the household that could be elderly, medically compromised, pregnant, childcare. That the lockdown has clearly showing an impact on mental health and financial hardship. So we need to keep mindful of that. Next slide, please. So we've touched on this, and you know, again, I'm just going to this from an ethical point of view, that the quality of the testing or the standard of the testing is dependent on the technique. Now, I have heard, I mean, and I'm from the Northwest, and I know that there's a lot of the Northwest has got a high numbers of COVID being affected patients over there. And I know in hospitals, they're basically doing fit checking, where we are going through the fit testing initiative. So the important thing is consider the ethics in the quality of fit testing that you're going to have. Next slide, please. And make your own risk assessments. Some things are more risky than others. And just lastly, I just want to bear in mind the religious considerations. So there are gentlemen out there of different religious backgrounds to whom their beard is important, and that is such a sacrifice actually for them to have to wear a respirator, and that's something that in sociology we will need to consider. The next slide, please. But you know, for style purposes, some people may need to reconsider their image. And the next important slide is that at least my wife is delighted that my beard has to go, and this is an image of me just proving that I'm not clinically active at the moment. So my beard is going to.
Thank you, Sami. I look forward to. I'm with your wife there. I liked the mustache before and the clean shave, but there is a solution for you. So loose-fitting respirators that we haven't talked on. Loose-fitting means that you don't need to shave. These are the possibly where the future is, but they're more expensive. There are positives and negatives. There's certainly going to be a drive into RPEs in healthcare. Most of the things that we've covered today are industrial respiratory protective equipment. I am sure in healthcare, because now that we are considering a lot more the airborne pathogens, we may consider other things. The most basics is what will get us safe, getting into, out of work. Our mental health, we need to be cognizant, we need to be aware of, as well as the basics of washing our hands, because contact, droplet, aerosol are all as important. Probably contact, one of the most important things, as well as droplets for us, obviously, and aerosols. Last but not least, I think we are at 9 o'clock, so our time is done. Thank you, Drew, very much. This is a QR code to a post-webinar questions. So if you still have any questions, we will take some of them now if you're still with us. If you're not with us, we will post you this questionnaire. You can ask questions. Please rate your confidence in what we've talked about. That will help us take it forward. Any feedback on today, please do. There is at the end a chance to put your name and contact. It's not for marketing. It's simply to give you answers to these questions and send you some resources and the list of evidence and frequently asked questions from today, and give you a list of resources if you wish.
I think that was actually very, very good and comprehensive, rounded off quite well with the questions I asked and Sammy answering as well. So we're really helpful with that. I think there are some questions, and maybe we'll put a few of them across, which will be important, really.
Shall I stop sharing, or?
Yes, if you can keep it on. You can keep it
Yeah.
on for people who are watching it. It's not a problem.
And guys, before we delve into the questions, don't forget healthcarecovid.org. It's an important study, and I think we need to put across what dentistry is going through as well.
I need to. Can you just put that slide back up again? Really, please try and jot it down or make a mental note of it. Healthcarecovid.org. It's extremely important data that Kareem is the lead researcher in the anaesthetic department at Guy's and St Thomas's. So he's gathering this information. It's extremely important for our profession. You'll notice in there that there is clear categories for dental therapists, dental nurses, and dentists. It's important that the data is captured so that the profession can develop with it. So I'd really appreciate you trying to complete that. And the information that's coming through already is eyebrow raising. So please help us by filling that in.
I think that's very important. And for those who are with us, there's a post-webinar survey I've put in the comments below, which is very, very important. I think there's lots of questions around the fit testing and, where can we get training to be an accredited fit tester? We had Angela asking, would you come and fit test their practice? How does that all work?
If I can take one question at a time. First of all, there is limitation within our system, within the UK and healthcare in fit testing. So unless you are an urgent dental care center, I wouldn't clog up the system, or I wouldn't recommend you in clogging up the system. There's a national response, and by the same as stockpiling PPE, by getting trained, if there is I'd recommend a local area team approach and a national response being coordinated. There is workforce planners, there is local area teams that are planning the need within their areas. The private industry is also considered as well. So, but if you were to get training, the gold standard is having an accredited course in being a fit tester. And that's an accredited course, not an accredited provider. There is also an accreditation system, which is by the BSIF Fit to Fit scheme that accredits fit testers. And that's the resource that I would direct people towards. But the same as not stockpiling, if you're not within UDCs, I wouldn't recommend it. I'd recommend working collaboratively within your local area teams and accessing those resources, and do it appropriately in appropriate time. The sticking point is not only the courses, but also the testing solutions, the testing kits. So by taking it away from the system, you're leaving frontline not able to deal with it. Part of the issue where hospitals that are not fit testing is not because they don't want to fit test, is because the capacity of being able to manage that is perhaps not at where it can be. So by taking fit testing away and fit test training away from trusts, then you're contributing to part of the problem, in my eyes.
Okay, and I mean, Goran Stonjevic was asking, I think it was regarding one of the FFP3 masks. I think when Ket was doing the demo, what happens after the hour? Do you need a new mask again, ideally, or do you reuse the same mask? Or was it Ashwin who said he can last with it for an hour? One of them was saying that, and that's when the question came in.
The fact is, once you've taken that mask off or broken the seal, the inside of it is going to be contaminated. So realistically, you can't use it again if you've moved it, if you've taken it off and broken the seal. Also, we have found that they don't adapt well to your face again on the same. So off the face, in the bin is the suggestion.
Also, Kat did not use a brand new respirator today. She used a demo one, and we see the demo ones. The elastics are loose, and once in a while, as we're doing the demo, they'll snap, and Kareem will second that as well. You want something that protects you and lasts and will not snap midway procedure. So these are disposable. They're designed to be disposable, worn for the least amount possible. However, local policy and local standards should be followed. And if they are sessional, then so be it.
And are we
You
advised
also have to remember, sorry, about the sessional use. So the PAT gave some updated guidelines, was it 3 days ago on the 3rd, about sessional, single use, all that kind of stuff. In all the guidelines, it's very clear, if you're doing an AGP, everything is single use, disposable.
And is it valved or non-valved when you do it with AGPs? That's the other question.
There's no guidance where to say to use valve or non-valved. That's not part of their guidelines.
We don't know, as Ashvin said. An FFP3 is designed to protect you. The valve is designed to make it more comfortable for you to wear. The FFP3 is to protect you from aerosols. The in and out, you're not going to create an aerosol yourself. You may create a droplet. So for me, the logic says, although I don't know, although there is a body of evidence thinks that healthcare maybe should be wearing a two-way filter, especially perhaps in shielded or on high-risk environments. But in my eyes, we're protecting the respirators for aerosols. Maybe we're not generating aerosols. We just need a barrier to protect the patient from us, but from the aerosol being generated from a potential carrier, that's what we're wearing the RPE for.
Okay, and somebody is asking, we got masks which were produced in 2016 and possibly retested. Can masks be retested for proper use and given a new expiry date?
So, manufacturer's guidance and Public Health England guidance is what I would follow.
Okay. And similarly, there's a question from Sudhir Radia saying, in the absence of trained fit testers, how do we proceed? Different types of masks will need new fit testing. Do you think manufacturers will provide such facilities? How do we proceed? What are the thought processes there?
So manufacturers already help with fit testing.
Okay.
And big suppliers help with fit testing.
Okay.
The way going forward, if fit testing with us, then we see fit testing as being part of a practice. As I've told you, I've coined the term NPD, so new professional development rather than CPD. There are new things that we need to learn as teams, and we see fit testing as an area of NPD rather than CPD. But it needs to be quality assured, and you want to know your team to be well protected.
A couple of other things. Trishan Mahi, what do you use to disinfect the reusable respirators?
Following manufacturer's guidance. So,
okay. And Jay says
most of the reusable ones we follow manufacturer's guidance and make sure that manufacturer's guidance is following Public Health England guidance as well.
And Jay Josh is saying, can I ask what happens if sorry, go on. Hello?
I was just going to say about the reusables. So what we do is we after each use, you wipe it down with Clinell, inside out, and then once a day you should really, depending on the guidance, but ideally you should disassemble and clean it with soap and detergent. Remember, the virus is actually quite it's quite a fragile virus, so soap and warm water is usually enough to kill it. So we do that once a day at the start of each shift. Clean the mask thoroughly, but between uses we use Clinell wipes. But as Tarik said, you should really check what the recommendations are of that.
Okay.
And the reusable any RPE should be part of your practice standard operating procedure.
Okay, so it should be in there. With the
should be in there. And for reusables, there's a step further, is that you should have a RPE program where it's maintained well looked after. So as part of having a reusable, you as a wearer should be instructed on how to dismantle it, as Kareem will do on a daily basis. On a monthly basis, he will inspect it, make sure that it's still has its integrity, is still the same, there's no malfunctioning parts, it hasn't been modified, and it's recorded. That we should keep a record of the maintenance and inspections of our reusable respiratory protective equipment, the same as we test or check our AED on a daily basis, or our medical emergency kit on a weekly basis.
Okay, and J. Josh is asking, what happens if you need to work with a microscope, for example, complex endodontics? Have you got solutions around that?
So as part of the fit testing process, we look at workplace. Whenever we can, we do the fit testing within the workplace. And we look at the ergonomics and how do you work with it. We're currently or in touch with product developers within one of the most prominent manufacturers of RPE, looking into what would be best solutions within dentistry.
Okay, that's great. There is a few other questions coming in. If you're happy, I will send you the link. In fact, it's a very, very good discussion. People have loved this very interesting webinar. There's a lot of positives there as well. Thank you, guys. Amazing webinar, important update for everyone. Very helpful in capital letters from Galeb Kareem. Lena Kantu says, thank you, great content. Rebecca Bray says, great webinars. I mean, it's phenomenal, guys. What you've put together, I'm very grateful. We've had close to 708 viewers tonight, but there are lots of questions. In fact, there's one from Andrew Shelley, which I may finish with. Could the speakers clarify, are these procedures recommended for just urgent dental cares, for all practices until we're sure the pandemic is over, indefinitely dental practice, or who knows? He's sort of saying, where do you put the complexity in?
So I'm going to answer that from the sort of ethics point of view.
Yeah.
So naturally, we are going to follow guidance, but we're also going to make our own risk assessments. This may well be an HTM 0105 revolution happening all over again. So we don't know. It may be that it becomes a regulation that we have to follow. If it's not a regulation that we have to follow, then we make our own risk assessments. I'm going to give you my own personal point of view, and my wife says I'm sitting and watching the news all the time, so I'm getting the heebie-jeebies. My own point of view is I think you can't protect yourself enough. So irrespective of the of regulations or guidelines, I'm going to personally, when I put myself in the clinical environment, do my utmost to protect myself, my colleagues, and my patients.
If I can add to that, Drew, behind me pictures of my children. I haven't put that there for the presentation, but essentially by me going to do fit testing, or the team going to do fit testing, we're putting ourselves at risk. I'm putting my family at risk. So I and anybody doing fit testing should be limiting it to absolutely necessary. And what I think fit testing should be is part of a coordinated approach by the local area team, in coordination with the local area team. It does not matter if it is NHS, private, we're all as a profession, and it should be done to a high standard and the quality maintained, not just by doing any course and doing any kit and do it in any way.
And if I can also add, there's a lot of loose and fast, it's very unclear what is an accredited and what is a competent fit tester. It's not set in stone what you need to do to be competent, and how do you maintain competence, and how do you gain competence in that. So choosing your fit tester is also very important, and also looking in your environment, because obviously a lot of these are industrial standards. So getting an industrial person will be able to give their point of view, but obviously from a health, we're focused on the healthcare point of view. We're not saying that we're not going to, We're creating obviously lists of people who need to be feet tested and so forth, but obviously that's where we have to prioritize currently what we need to do and then what going in the future.
And if I can add to that, there are a lot of people in the industry that are knowledgeable, experts in this area, and we've been fortunate to come in contact with some of them, and we're developing a network of experts, and we're happy to recommend some experts in the field as well. Yeah, it's an exciting new field to us, and but all I would say is coordinate within your local area team, within your LDC, within your LDN, using your local trust as a point of view, and coming together as a professional community.
Yeah, that's very useful. So thank you very much. Very useful. I think somebody's put a document from the Troslesh brothers. I'll send you that link. If you can put your feedback in the comments in due course, that would be brilliant. But everybody else has really enjoyed this. I think the best way to say it is Shanti Madhupusi saying the most useful webinar in the lockdown. Awesome. Can't thank you all enough. So there you go. You have been awarded the most awesome webinar in 6 weeks, and that really says something brilliant. I think the knowledge shared there was absolutely positive. So, you know, we have to say 788 people live have taken some form of information through this. So I appreciate that. Thank you, Kat, for doing the demo. How do they get in touch with you if they need more information? All of you, any of you, or one of you?
Can share our screen.
There you go.
So there's our individual emails. Get in touch, but I urge you to fill in this questionnaire better, because then we have all your contacts rather than clogging up our email inboxes, because with 700 people, I think we won't be able to manage the next few days.
No,
So I urge you.
I mean, put it back because
yeah, take it, but I'd urge you to. You can take a picture of it. I'd much prefer.
I'm always of the opinion that, you know, it's. I've always had an open door policy with all my friends and colleagues, as we all do. I'm happy to be contacted by anyone at any time.
Yeah, same here, but please fill in the questionnaire as well.
And fill in the questionnaire.
Awesome.
And the survey.
I think that's important to do all of that, isn't it? And for those of you who've asked for the document of the 38 questions, you can actually download it on the website. If there is any other things that you want to put on the website, Tarik, Sami, Ken, anyone, you just go to Tubules Live Aid. Obviously, at the top in the past webinars, you will see today's webinar with the protocols and everything else. If you go to discussion forum, we've put a little post, the 38 questions to enable the risk assessment in your practice, and you can download the document from there. If there are any other documents that Tarik, Samir, Sami, Kareem, Kat, or Ashwin have, we will add them on here as well. CPD will be available for this from tomorrow, but that's been an awesome evening. It has genuinely been the fastest 2 hours for us. A lot of information. I thank you all for sparing this few hours. It's phenomenal to the team, and all of you are doing a great job. Keep it going. As I've always said, Tubules Live together over the last 6 weeks has been giving you information, inspiring you, and giving you that positivity to get back in practice. I hope we're continuing to do this at Tubules. This has been Tubules Live together. We
Drew,
might be in isolation.
Drew, if I can just interrupt you for a second.
Yeah.
I wanted to thank you, for this opportunity, and my fellow team members and panelists. Also the team that are, I know some of them are listening and behind us, we wouldn't have been able to do, and some of them are not. I know we would have been able to do any of this without the collective effort and the collective support and the collective leadership in very stressful, high intensity and risky times. And lastly, our families, because sometimes they are forgotten in all of this. So thank you.
Yeah, I think we have to say that Hamid Karimi passes his regards to you all. And
Bless him.
there is a lot of comments. Seriously, I think people have said thank you the most times I've ever seen in this 6 weeks. So your team, all the people around you, as you say, your families, everybody giving you support. As I've always said, we call this Tubules Live together because we all may be in isolation, but in our little bits, coming and working, we're always together. This has been Tubules Live together, helping you through this period. See you everyone tomorrow. Have a great evening. Thank you.
Good night.